Okay, we're going to turn over to a second case here. So this is a 62-year-old who had a history of chronic DVT with venous stasis ulcers and some polysubstance abuse, who had presented with abdominal pain, nausea, coffee ground emesis, and melena. And this patient had been discharged from the same hospital where he's now presenting just 5 days prior, where he was admitted for the same symptoms, but improved with IV hydration along with some antibiotics. He was scheduled to have a scope as an outpatient. Unfortunately, during that hospitalization, in light of his history of chronic DVT, he developed a new acute DVT in the left lower extremity, and so was discharged on rivaroxaban at the full treatment dose, 15 milligrams twice daily. And he had taken his last dose just 4 to 6 hours prior to this now presentation with abdominal pain and coffee ground emesis. On exam, the patient's tachycardic to 128, blood pressure is low, much lower than during his prior admission, running 93/50, and then on repeat shortly thereafter, 87/46, but satting well. He appears pale, diaphoretic, tachycardic, but with a regular rhythm. Had some abdominal guarding, but no rebound. And in the lower extremities, there's 2+ pitting edema on the left, where he has the new clot, as well as some chronic changes, probably post-phlebitic in nature, on the right lower extremity. So on the left column, we have the labs on discharge, and on the right column here, the labs now on this readmission. So he left the hospital with about 8.5 grams of hemoglobin and now returns with about 6.5 grams of hemoglobin. He left the hospital with renal insufficiency and a creatinine of 1.98. He's now presenting with acute renal failure with a creatinine of almost 6. He didn't have an INR on discharge, but there's an INR prothrombin time performed on admission, yielding an INR of 1.43. Also, on readmission, his white blood cell count has spiked up a bit, suggesting something's going on. So how would you classify this bleed according to our new chest AFib classification? Now, this is not an atrial fibrillation patient. This is a VTE-treated patient who's on acute treatment for a new clot. But in terms of assessing what kind of a risk we're dealing with, would you say, A, this is a major bleed, life-threatening, B, a major bleed, severe but not life-threatening, C, a moderate bleed, or D, a minor bleed? So what would the emergency room physician think?
So I think the key to me was the pale, cool, diaphoretic and the low blood pressure. So there's a patient in shock. I think that's life-threatening.
Yeah. So, and then another thing we always try to teach the residents and fellows is that during an acute bleed, you may not get equilibration of your hemoglobin. That may continue to drop as plasma volume is mobilized during this shocky patient's course. So I would agree, this is a very concerning patient. He's dropped about 2 grams of hemoglobin at this point, which does meet the criteria for a major bleed, but chances are he's actually a little lower, especially when he gets resuscitated. So what additional information do we need on this patient? We kind of just talked about how serious this bleed is. Now we're guessing that this patient's last dose of the rivaroxaban is 4 to 6 hours. Anything else that we're missing here, information-wise?
I think that, so to make my decision to reverse, I think you've given me everything I need to know.
Okay.
So he's got a fairly recent dose. He's got bad kidneys. So whatever he took has not been cleared. At least not much of it. And he's in shock. Yeah.
So I think that's one of the key things we were pointing out about this case is that this patient left with renal insufficiency and now he's in acute renal failure. And so chances are he's not clearing the drug he's been taking, including that last dose 4 to 6 hours ago. So that's a big concern. And I think in this case, we would agree that we don't really need additional coagulation testing to make our decision in terms of how to approach it. So which of the following would be your next step? This patient's looking a little shocky to you. Do you administer FFP, administer some blood, go straight to your 4-factor PCC, or go straight to your Andexanet? So, the pretty standard approach in the emergency room or in a trauma center to resuscitate, which was done. He got IV fluids. He got 2 units of packed red cells. He did have a nice bump in his hemoglobin, but he was still tachycardic. And so the next step was to go ahead with what we had at our emergency room, which was Kcentra. That dose is 25 units per kilo. As you mentioned, they would just give a flat dose of 2,000 in some institutions. We did it weight-based. The patient did not have a perforation, so rather than going straight to the OR, GI was consulted. And after the time of the Kcentra administration, no further red cells were required, and the patient's vital signs did stabilize. So ultimately, there was something that bled that we were able to control with relatively conservative, non-invasive measures. So, these cases come all the time, and I think it can be a little bit gray about who meets criteria for anticoagulation reversal. So let's say you had brought the patient in, given him the couple liters of fluid and the 2 units of red cells, and his vitals all stabilized. Would you have foregone the reversal at that point?
That's a tricky question. So when the guy presents in shock, I think I would probably do a bunch of things all at once, which is do 1-to-1-to-1 transfusion with, unit of PRBCs or unit of plasma, not as a reversal agent to plasma, but as a sort of volume expander, and then platelets, and then order the reversal agent, which would take some period of time to be done. With a hemoglobin of 6, and a fairly old guy who came in with that blood pressure, he would have to get really stable really fast for me to change my mind about the reversal agent.
Great. So I think that's exactly how our team approached this. Is while they're waiting for the PCC to come out, they're resuscitating the patient and trying to make sure that they've got him stabilized, ruling out a perforated bowel. So I think just as you say is how it was approached. We did not have Indexinate at our emergency room at this point. Would you have had a particular preference in this case, PCC versus Indexinate, if you had both available?
So I think if you look at the entry criteria to the trial, this was the GI patient we were trying to get in the trial. So there's signs of shock. Okay. Certainly at the sicker end of GI bleeds, not one of these slow bleeds that you can just sit on and wait for a while. So I would give him Indexinate, I think. Okay. Yeah.
Great. And then there's one other question we threw in there, was the dose appropriate? So in some of the guidelines, they take the PCC dose 25 units per kilo as high as 50 units per kilo. So we went on the lower end, closer to that standard dose that you mentioned of 2,000. Any criticisms there?
Absent a whole lot of evidence to support this, that's the guideline we developed in our own system was for head bleeds, use 50 per kilo, and for other bleeds that are sick enough to require it, use 25 per kilo. Okay, great. I think that's our standard approach as well. Well, this has been a great discussion. Hopefully you got a lot out of it, and we've enjoyed going through these cases. Yes, my pleasure. Thanks, Kate.
Thank you.